Assalamu alaikum wa rahmatullahi wa barakatuh. I hope everyone can hear me. Can you hear me, guys?
Yes, clear.
طيب. طيب, a bit of history, as always. So the first implantable basing device in human being, as you can see here clearly in 1958. And the guy which has why is not moving? I need to go from here. And this is the person who has it. His name is uh, Arne Larsson. He's a Swedish guy. He has a fully implanted pacemaker, which you can see in the bottom, and done through thoracotomy, done by cardiac surgeon, not by a cardiologist. And the first implanted device was failed only after 3 hours. And after that, he had another device which failed after 2 days and required 26 pacemakers through his life. He wonderfully lived till he was 86 years old. So technically, he has 43 years of pacemaker since his pacemaker implanted. So that's a bit of history. The pacemaker component are main two groups. The first is the implantable pulse generator, which has three components, the pacemaker battery and the circuitry, as well as the connectors for the leads. The second major component is the leads themselves. I put between two brackets wire because when you have temporary pacing wire, it is not going to be a lead, it's going to be a simple wire. And that wire has a cathode and anode. And that cathode and anode vary depending on the type of lead. For unipolar lead, the cathode is going to be the tip of the lead, and the anode is going to be the body tissue. So this is a simple pacemaker, which has major three components as I mentioned. In the top is the connector where the lead get in, and that's basically single chamber pacemaker, as you can see, because it has one single connector. And the circuitry, which is labeled as the COMOS chip. Basically, this is a chip which works like a microcomputer. And the change in the size of the pacemaker is largely due to the development in the microchip technology. With more small chips available now, soon we may have the pacemaker size halved or even become 1/4 of the current pacemaker. The largest part of the device is normally the battery, which is mainly lithium iodine battery. But this even gets smaller and smaller with time. Now there is a device which only around 2 centimeters in diameter and weigh roughly around 50 gram, which is not still widely available, but that tell you how far the technology has been going from the beginning. If without the technology of the microchips, the device would be the size of an old TV. So the leads, normally there is two types of leads. Actually, there is many types of lead, but I'm concentrating in the simple type of pacemaker. The unipolar lead is largely very small lead with one central ball through which is connected to the myocardium. And as I said, the cathode, which basically the ball through which depolarization happening to the myocardium is at the tip of the lead, while the anode through which the stimulation go back is going through the tissue of the human being himself. So the can representing the anode for the device. The characteristic of this lead is normally very thin. It is very thin and has large pacing artifact because the area between which the stimulation is delivered to the where the stimulation getting back to the device is very large, from the tip of the lead up to the can of the pacemaker, depending on where is this pacemaker located. If subpectoral, that's going to be a very large distance. If it is abdominal device, like in epicardial leads, then the artifact is going to be less. Because of this wide area of delivery of stimulation, it is more susceptible to interference from the surrounding environment. Any electromechanical interference can happen, and that could be from electricity source, from electromagnetic field, or from other tools like drills or even vacuum cleaners. So the unipolar lead problem, the main problem with it is very susceptible to interference. I must say this lead now largely not available for transvenous, except for certain type of device. The biventricular pacemaker, still there is unipolar type of lead. And for pediatrics, because sometimes the pediatrics may be very small and you will not be able to put a bipolar lead, you may need a unipolar lead. But largely the bipolar lead now become increasingly smaller. So it makes the need for using the unipolar lead for the transvenous system very minimal. It is widely used for epicardial system because it is easy to implant unipolar lead, and most of the time the available lead is either unipolar, bipolar, only on demand for the epicardial system. The bipolar lead, as you can see, it has two components: the tip, which basically the cathode, and the ring, which is basically the anode for the device. So the depolarization wavefront going through to the myocardium through the tip of the lead and going back to the device through the ring, which basically the positive electrode. And that makes the lead a little bit bigger than the unipolar lead. But as I said, increasingly it is becoming smaller. The current size of the unipolar lead is between 5 to 4 French, so very small. If the French is 0.3 millimeter, it is roughly around 1.2 to 1.5 millimeter in diameter. So it is still small, comparable to the old type of leads. Has a small pacing artifact because the stimulus is basically from the tip to the ring, which is a short distance. And in addition to that, less susceptible to environment because all the sensing and capturing happening inside the myocardium, not like the unipolar lead. So you can clearly see now the depolarization wavefront is going from the tip to the myocardium, returning back to the ring of the electrode. So based on that, we must understand that in any patient who is going for preoperative procedure, the polarity really must be bipolar. As I said, intravenous unipolar lead are not available anymore, but sometimes during the
أي حاجة بايبولار قبل operation.
sorry
لا
sorry
ده واحد المايك فاتح لكن قفلته. سوري دكتور حسين.
okay, that's fine. So normally sometimes even if you implant a unipolar lead, the parameters of the leads may mandate you to program it unipolar because, for example, you have a better sensitivity, better threshold using tip to can, and you prefer to program that to maintain the battery longevity. But if this patient is going to go for operation, that especially if he's a pacing dependent, that will risk him losing pacing during the procedure due to interference. Remember here, you don't need even the diathermy. Just moving the patient around can result in myopotential, and that could be detected by the unipolarity as intrinsic cardiac activity. So preoperatively, for any type of operation, you must change the polarity to bipolar. If bipolar sensing is not possible, prohibit then unipolar diathermy usage in pacing dependent patient, and make sure that this patient has constant pacing throughout the procedure by maybe putting a magnet and canceling any sensing. For BGR, if bipolar pacing is not possible, not only sensing, if the pacing is not possible through bipolar polarities, then you must put a temporary pacing wire, or you have to be very quick really, because the moment you are going to take the pulse generator from the pocket, the patient is going to go to asystole because he lost the second ball for bathing, the positive electrode basically for the pacing. Any questions so far? Please try to stop me if I sometimes I make assumptions because, as you know, electrophysiologists are very bad people in explaining sometimes, and they use a lot of jargon language. So if you don't understand anything, don't hesitate to stop me.
يا دكتور سلام عليكم ورحمة الله.
وعليكم السلام ورحمة الله وبركاته.
بص يا دكتور شوية يتكلم معانا عربي يعني شوية اصطلاحات يعني
اتكلم معاكم بالعربي كويس. طيب
سمبليفايد يعني الحياة.
طيب
شكرا.
طيب الكلام الفات ده فهمته كله ولا لا؟
لا لا مفهوم الكلام.
الكلام
مفهوم.
الفات مفهوم. طيب في أي سؤال so far؟
لا لا فيري نايس.
ما في أي سؤال. طيب
وبس يا دكتور حسين sometimes نحن بيكون معانا ناس ما بيفهموا عربي، يا الدكتور لسه سال يا دكتور هشام ولا منو؟
أنا قاسم، دكتور قاسم.
غاسم معلش. هاي بس بعد مرات ناس بيحضروا معانا في اليوتيوب بعدين في التسجيل هنود وكده، وناي ما بيفهموا العربي، عرفتها؟ يعني بنكون حرمناهم برضو من هنا، هم موجودين كتار عندنا هنا. فيعني ما في مشكلة دكتور حسين، ممكن تو simplified يعني his language وكده، لكن أفضل تكون يعني in English. ولا رأيكم شنو عشان ما نحرمهم من المنفعة برضو؟
كلامك صحيح.
Decide guys if you want. Is my English language good or very complicated?
هي أنا قصدي إنه شنو يعني إحنا we are not all cardiologists يعني.
You are not a cardiologist. Okay.
Yes. Yes.
Okay. So you mean that you need more in-depth explanation?
Yes. I just to simplify it يعني.
Okay. Fair enough.
قبل في سادسة ابتدائي كده.
خلاص. بسم الله. جدا جدا جدا. I will try my best to simplify it.
اوكي شكرا.
طيب. Just to show you how the unipolar signal going to be seen in the ECG, you can see before each P wave, the B wave is basically the atrial depolarization wave. Before each B wave, there is big spike. This spike will not be that size if it is bipolar. But because it is unipolar, it is very large. It is almost equal to the QRS amplitude. So the other difference between leads, we have what we call passive fixed lead and active fixed lead. And basically that is represent the way the lead is attached or connected to the myocardium. The passive fixed lead basically is connected to the myocardium through small tines, as you can see, star-shaped tines, and that tines basically going to anchor the lead to the trabecular of the myocardium. If the lead is implanted in the ventricle, the right ventricle, or it keeps the lead in the atrial appendage if the lead is inserted in the atrial side.
معلش يا دكتور حسين، جاتنا رسالة في الشات قالوا يعني شوية الصوت بعيد عليهم يعني. if you can increase the tone if that is okay for you.
خليني أنا أحاول to increase the volume of the sound from here. كده سامعني كويس؟
Yes, clear.
طيب. طيب. So the basic fixed leads basically connected to the myocardium through the tines, which basically a small star-like projection from the body of the lead. And that tines basically anchor the lead to the myocardium through the trabecular in the ventricle and in the right atrial appendage. The problem of the basic fixed lead, it is normally has a very high rate of displacement, especially from the atrium. And the other thing that the threshold may increase with time, because what happens, the tines is not going to be the final connecting mechanism. These patients are going to develop fibrous tissue, which make the lead more connected to the myocardium. Although sometimes the tips of these leads is coated with steroid to reduce that fibrous interaction, but this fibrous interaction sometimes going to happen anyway, and as a result, chronically the threshold may increase for this lead. The other things about the basic fixed lead, if the patients require the lead to be extracted, means that removed due to infection or due to failure of the lead, in that case, it is more risky because it is more connected to the myocardium, and it may result in complication like severe vena cava tear or tamponade. The other problem with it, it mandates you to go to certain location. You will never be able to put your basic fixed lead in a septum or basal area because, or the outflow tract, because it doesn't have mechanism to stay there. It will drop immediately to the apex of the heart. So that's why most of the basic fixed leads are inserted apically. Almost exclusively, they have to go to the apex of the RV. And cardiologists are more aware of the fact that the apical pacing now is less favorable because of the associated risk of pacemaker-induced heart failure, which basically resulting from high burden of pacing, the patient may develop left ventricular dysfunction. So the basic leads is phasing out, unfortunately. The last time I have implanted a basic lead, I can't remember, to be honest, maybe more than 15 years ago. In the other hand, the active fixed lead is using active screwing mechanism. Basically, the tip of the lead have, as you can see here, there is inside the lead, there is a screw, and that screw can be coming out from the tip of the lead and connect the lead to the myocardial tissue. Because of that, it has low risk of displacement. The threshold will improve with time. Most of the time, you will have a high threshold sometimes during the implant. And once the patient goes through the acute phase of pacemaker implant, the threshold will improve. And the same thing, sensing improve as well. And it is easy to extract. My personal experience, you can extract active fixed lead even more than 1 year from the date of the implant without a need for laser lead extraction. We know that if you want to extract a lead implanted more than 1 year, most of the time it will be well adhered, well attached to the myocardium, and you need to use a special type of laser extractor to be able to remove that lead. But with active fixed lead, because it is less, it is less adhered to myocardium through fibrous mechanism because of the one steroid coating, and two, the main mechanism of connection is through the screwing the lead through the myocardium. And it is not very long. The screw is most of the time 1.8, maximum 2 millimeter in length. So it is not that large screw that which may result in perforation and tamponade. So this is a preferred type of lead now, and almost most of the leads available now are active fix. You will hardly find basic lead for pacemaker. Anything so far? I hope I am making it more simpler now. ولا لا؟
لا تمام يا دكتور.
تمام. Okay. The epicardial lead, in the other hand, are mostly unipolar, and they have different type of mechanism of implant. They are sometimes implanted through open heart surgery. I have implanted few of them by the help of the cardiac surgeon, obviously. And sometimes they can be implanted through minimal thoracotomy. And as I said, they are mainly unipolar. You can get bipolar epicardial lead, but they are mainly unipolar because the unipolar one is easy to implant. They can be connected to the myocardium through minimal stab or suturing, or sometimes they can have active screwing mechanism like the lead in the bottom. The number 3 lead has active screwing technique to the myocardium. They mainly use in pediatrics formulation because of the size. طيب, let us have a case. 31 years old. لازم تونس. طيب. So case 1, 32 years old man admitted after road traffic accident, has a history of pacemaker implant 3 years ago, does not. What happened?
Dr. Umar Abakar, please, if you can mute yourself. And I mute you, and you will unmute yourself again. And okay, تفضل دكتور حسين.
طيب. So this is a 32 years old man admitted after road traffic accident, has history of pacemaker implant 3 years ago, does not know what was the indication, and the ER physician did this ECG and he thinks that the pacemaker is not working. Anyone to volunteer to answer? What do you think, guys?
We just can't see the spike in the ECG.
So there is no spike in the ECG.
Yes, it's otherwise it's normal sinus rhythm.
Normal sinus rhythm. Does the rate indicate this patient has a pacemaker or no?
والله هو موزون يا أخي. Indicates no spikes.
No spike.
Yeah.
So from the ECG, you don't think there is any indication this patient has a pacemaker?
Yes.
Sometimes absence of the spike doesn't necessarily mean that the patient has no pacemaker. But what other clues that the pacemaker may not be pacing now? The rate, what do you expect the pacing rate normally?
Is bradycardic. The rate is the basic plus 30, right? It is the capture rate.
So the rate normally, the rate of the pacemaker So the definition will come later on in the talk, maybe this talk or the next talk if I have a time. Guys, I should tell you that 9 o'clock sharp I need to finish if I can. Anyway, so the pacemaker has normally what we call the base rate. And the base rate is basically the minimum rate that the pacemaker will pace the patient if the patient intrinsic rate is not reaching it. For example, if the patient heart rate is 60 and the programmed base rate is 50, the pacemaker will not pace, will just keep watching, watchful monitoring. If the patient heart rate is 30 and the pacemaker base rate is 50, it will immediately start to pace and you will see pacing spike. So normally, most of the time, the pacing rate is unlikely to be less than 50. If you look at this patient, his heart rate is less than 50. So that make you think, oh, this patient may not have a pacemaker. So you did the X-ray and you find the patient has a pacemaker. So what is the job? What is the primary job of the pacemaker, you think? Anyone?
Can you repeat the question?
What is the primary job of the pacemaker?
It's to increase the heart rate, right? It's forbid the brady, the main cause of the bradycardia.
And you think that the main job of the pacemaker is to increase the heart rate?
Yes.
طيب لو قلت لك the main job of the I put an eye in the place of the pacemaker. The main job of the pacemaker is actually to watch what the heart is doing. And based on that, we'll decide what's the next step. So basically, it monitors that through the intrinsic polarity of the lead tip to the ring. And that's what we call sensing. And as a result, if it sees QRS, it will do nothing. If it doesn't see QRS, it will pace them. So the primary job of the pacemaker and even the ICD is sensing. We think that pacing is the primary job, but the pacing itself cannot happen without the sensing mechanism of the device. So most of the time, most of the device will be just doing sensing. So the sensing is primary pacemaker function, ability to sense intrinsic cardiac activity, which is basically atrial activity, ventricular activity, and even ventricular repolarization. So the pacemaker is basically sensing atrial depolarization, which is represented by the P wave, ventricular depolarization, which is represented by the R wave in the ECG, and it senses as well sometimes the ventricular repolarization, which is represented by the T wave on the service ECG. We will go through the pacemaker nomenclature later on, but it represents the second letter in that. Although, as I said, it is the primary function, should have been the first letter, but it is the second letter when we go through the coding of the pacemaker. How do we name the pacemaker? It is more susceptible to external interference, unlike the pacing. Pacing itself just requires the pacemaker to deliver electricity to depolarize the atrium or the ventricle or both. But that is not going to be affected by any external environment. It can be affected by intrinsic factors like the lead connectivity to the myocardium or electrolyte disturbance, or if the patient taking some medications. So intrinsic interference can affect the pacing, but it doesn't affect the sensitivity. The sensitivity, on the other hand, is susceptible to very much external interference like electromagnetic field, electricity, or even mechanical movement can affect the sensing. And it is essential for device function. And just I go through type of pacemaker, depending on the functionality, most of the pacemaker do what we call demand pacing. And demand pacing means that the pacemaker will only pace if the patient need pacing. So this primarily for bradyarrhythmia, sinus arrhythmia, sick sinus syndrome, or AV node disease like 2-to-1 block or complete heart block. So the demand pacing is basically to treat bradyarrhythmia, and it requires sensing, because without sensing, it will not know if the heart rate is slow or fast. Force pacing, in the other hand, is when we want the pacemaker to pace all the time or most of the time. And this is basically the biventricular pacemaker for heart failure. Although the patient has intrinsic rhythm, but the intrinsic rhythm is not favorable because it results in dysynchrony, and as a result, the left ventricular cardiac output drop down. And we want to improve that by making the pacing basically coming from the biventricular pacemaker. So this is kind of force pacing, but to be able to work, it needs intrinsic sensing. What happens here, basically, the pacemaker must be able to sense the P wave, and then to try to depolarize the ventricle faster than what expected to happen if it leaves the P wave to go through the AV node. The asynchronous pacing, basically here, what we call pacing regardless of presence or absence of intrinsic rhythm. And this special type of pacing, I will go through it in later stage. Interventional pacing, in another way, is treatment type of pacing, basically. It is anti-tachycardia pacing, like ATP. That's what the ICD do. Or suppressive pacing. Suppressive pacing, the other name of it is overdrive. That's basically used to treat or suppress arrhythmia, like VT. If you have a patient who keep developing VT, what do? You try to base the ventricle at a higher rate to suppress any new ventricular episode. Or it can be used even in the atria. If the patient has recurrent episode of paroxysmal atrial fibrillation, then you want to pace the atria at a higher rate to suppress any atrial arrhythmia. Rate drop is a type of pacing that you don't need really to know it is almost dying, but it requires intrinsic. So if you look at all type of pacing, the only one doesn't need sensing is asynchronous pacing.
دكتور
So
ممكن سؤال بس؟
اتفضل.
الامبلانتable cardioversion device, is it pace type of the pacemakers?
It can do pacing, yes. The cardioverter, the defibrillator basically are pacemaker with ability to deliver shock. So their primary job is pacing. They can pace, but in addition to the pacing, they are capable of delivering shock and terminate arrhythmia if it is atrial or ventricular arrhythmia.
So we can classify it as a suppressor?
It can be used as suppressor.
Okay, thank you.
The defibrillator can be used as suppressor. So for example, if you have a patient coming in a VT storm and he has an implantable defibrillator, ICD, and he is still continuing to get VT episode even after you have given him antiarrhythmic medication. So what you could do, you could program the ICD to base the heart at high rate. Normally you start at a low rate like 90 and then increment it by 10 beats each time. So you base the heart rate at 90, for example, and you wait. There's no more VT episode, so you leave the heart rate at 90 while you are using antiarrhythmic medication and correcting other possible underlying causes like electrolyte disturbance. But the patient continue to have a VT after you increase the pace rate to 90. You increase it more, you go to 100. And you wait, for example, for 1 hour. There is no any further VT episode. You will continue to treat other possible underlying cause and using antiarrhythmic medication. And if the patient has no further VT, you will leave the rate at 100 beats per minute. That not permanently, that till you get the patient through the VT storm episodes, till you have a definitive treatment through either correcting an underlying cause or the patient taken to the cath lab for VT ablation.
اوكي،
So
شكرا.
you could use it for suppressive pacing.
شكرا دكتور.
طيب, sensitivity is the ability of the pacemaker to detect intrinsic cardiac activity. As I said, B wave, R wave, or T wave. B wave is basically depolarization of the atrium, R wave is basically depolarization of the ventricle, and T wave is repolarization of the ventricle. What is the repolarization of the atrium? Anyone? Why you don't see the repolarization of the atrium? We see the depolarization of the atrium as the B wave, but we don't see the...
It's the
Zero.
PR wave, right?
Sorry?
It's embedded in the QRS complex, right?
Yes, it is embedded with... excellent, yeah. It is hidden by the QRS complex because the atrial repolarization, very low voltage. Whose the depolarization is a low voltage, so imagine the repolarization is going to be even a lower voltage. So it will be hidden within the QRS and T wave. The repolarization of the atrium taking longer time, so it will span the R wave and part of the ST, sometimes up to the T wave. So how the depolarization or repolarization of the atrium and the ventricle is sensed? So normally what happens, the device has a mechanism to sense intrinsic activity, and it is programmable. You can program it to a low number or a high number, but the lower the number, the less sensitive, and the higher the number, the lower the number is the more sensitive, and the higher the number is the less sensitive. So it is reversed. So if you program the sensitivity to 5, for example, you can see that you cannot see any, the device will not be able to see any of the complex. It will not see the P wave, it will not see the QRS, it will not see the T wave. So the number is high, but the sensitivity is low. High sensitivity number mean less sensitive. The device will not be able to detect any intrinsic activity. In the other hand, if you lower the number, you make it, for example, 1, the device become oversensitive. So the sensitivity number is low, but the device is more sensitive. It's now detect everything. So the adequate sensitivity is going to be able to detect, for example, if you are in the ventricle, you will be able to detect the R wave, but you don't want to detect the T wave, and you don't want to detect a far field B wave. So that's called adequate sensitivity. Maybe here in this example, 1.25 or 1.5. So the device here is capable of detecting what you want it to detect, which is the intrinsic ventricular depolarization. And you have hidden the repolarization, and you have even hidden a B wave if the patient had a far field sensing. For example, if the ventricular lead is very close to the atrium, it can see a what we call far field, mean that there is a wave coming from afar and detected by the lead polarity. So it see a B wave, but it will see it in a very small amplitude. And if you increase the sensitivity adequately, the lead will not see that far field B wave. So there is 2 types of sensitivity detection by the device. There is what we call fixed sensitivity. Here you program, for example, a fixed number, and the device will try to detect, for example, the R wave or the B wave based on that number. And that's most of the pacemaker, or almost all the pacemaker will use a fixed program sensitivity number. While the defibrillator, in the other hand, I will give you another example later on, use what we call auto-adjusting sensitivity. It starts at a peak and gradually reduce the number of the sensitivity to be able to detect any activity, because sometimes ventricular fibrillation, the amplitude of the wave will be very low, And as a result, you require the device to be able to see that. So that's why the ICD use what we call auto-adjusting sensitivity. It gradually, it starts, for example, at the peak of the detection of programmed activity. For example, it starts at 8 millivolt of the R wave. And after a fixed time, it will reduce it by, for example, 75%. And after another fixed time, it will reduce it by 50%. And after another time, reduce it by another 25%, till it reaches the baseline. And once it thinks that it starts to be closer to the next depolarization wave coming from the ventricle, it will increase back to the original amplitude. That's what we call auto-adjusting sensitivity. And almost all the ICD use auto-adjusting sensitivity to be able to detect a low amplitude ventricular activity like ventricular fibrillation or even ventricular tachycardia with low amplitude.
دكتور حسين لو سمحت لي،
تفضل.
لاحظت أنا في السانجود والميترونيك they put a fixed sensitivity for the atrium 0.5, Sanjud they put it 2, and Metronic put it 2.8 for the ventricle. While the Biotronic put it auto sensitivity for both atrial and ventricle. في أي explanation للحاجة دي من شركة لشركة؟
شوف دائما الشركات عندهم preferred programming mandated by the ability of their device. يعني حتى when you come to the QRS, for example, even if you go to the fixed program sensitivity, not all device is capable to measure peak to peak. يعني for example, if you have, for example, a QRS which has R wave and then S wave, some of the device have the ability to measure the QRS from the S to the peak R. So it's measuring the whole QRS. Some of device not. Some of device will only detect the R component or the S component depending on the depolarization wavefront. So most of the device is using what suit their device capability. For example, Metronic is regarded high-end type of device from programmability, for example. It has very high features. While Biotronic and Boston, from basic point of view, have a very low programmability. So they will use something that suitable for their device capabilities. It is like having a car. So someone have a car with a two cylinder engine and some with a cylinder engine. So each one will try to use a speed according to the capability of his car. But there is no really big advantage for the patient really, or it doesn't compromise the patient, by the way. Even the very basic mechanism of programming can be useful, because what they will do, they always have a safety margin for this programmability, and the safety margin is sometimes 5 to 8 times the intrinsic detected sensitivity.
Okay, thank you.
Any other question? شباب ما تخلوني انا امشي اشرح ساي وانتم ما فاهمين. زي ما قلت لكم احنا ناس الالكتروفيسيولوجي ار ويل نون ذات انه كلامنا بعض المرات بنحاول نعقد الكلام برانا. ف I حاول to make it simple if you do not understand. So far everything is good?
Yes, clear.
Yes.
طيب. So what happens if the pacemaker is not able to sense activity? So if we go to this ECG bit by bit, the tip of the ECG is basically, the tip of the tracing is basically the service ECG. And the bottom is what the pacemaker is seeing. So if you go to the top, you can see there is a spike followed by a QRS. And if you look at the bottom, you can see clearly written VP. This means that ventricular pace. So this is ventricular pacing. You go to the second QRS. I'm talking from left to right. You see spike, you see a QRS, and if you look at the bottom line, which basically what the pacemaker is seeing, you see V pace, indicating that the pacemaker is here pacing. If you go to the third, you can see a P wave, and that P wave followed by a QRS. But if you look at the bottom, corresponding to that QRS, you don't see anything from the device. So basically, the device is not seeing this QRS, which we are seeing in the service ECG. And as a result, it paced after the QRS immediately. And this is quite serious. Why it is quite serious?
R on T?
Technically behave like R on T. So if that spike, here fortunately in this patient, it is coming just before the beginning of the T wave, which indicate that it is falling within what?
Within the depolarization.
It is not within the depolarization. It is after the depolarization because the QRS is completed now. It is falling with what we call absolute refractory period. The absolute refractory period is interval between the end of the QRS and the beginning of the T wave. And during this interval, whatever amount of stimulus you are going to apply on the heart, you will not be able to depolarize the myocytes. So the myocytes basically refractory to depolarization. That's what we call absolute refractory period. Once the T wave starts, here it is starting what we call relative refractory period. The relative refractory period, the myocardial cell or myocytes are refractory to depolarization, but if you apply strong enough stimulus, you will be able to depolarize. And that's why if the stimulus fall at the mid of the T wave, this is basically the most vulnerable time of the relative refractory period. It can induce arrhythmia. So here the spike fortunately come before the beginning of the T wave, so the myocardium is still in the absolute refractory period. It doesn't capture the myocardium and no arrhythmia have happened. And you can see again, there is another intrinsic beat, P wave, followed with a QRS. If you look at the line below, the device doesn't see that. And as a result, it paced. Fortunately, here it paced after the completion of the T wave. Completion of T wave means that the relative and the absolute refractory period is finished. And here, if pacing happens, it will depolarize the ventricle and it will not cause arrhythmia. So you can see clearly here now, it happened after the T wave completed and as a result, capable of capturing the myocardium and depolarizing the myocardium. So V pace. Then again, this is appropriate pacing because there is no intrinsic rhythm happening before it. And there is another QRS and the device doesn't detect it. And as a result, it paced. There is another QRS, the device doesn't detect it. And as a result, it paced after, but here it paced after the relative and absolute refractory period completed. So here, as a result, the device is not sensing all the intrinsic QRS or R wave, And as a result, it is over pacing. And the danger of that, if this pacing happening in the what we call the vulnerable period, where the myocardium is possible to depolarize, relative refractory period, it can induce arrhythmia. I will show you later on an ECG showing you that. Clear this one?
Yes.
Yes, doctor.
وهي دكتور حسين we have to reduce the sensitivity مش كده؟
Here you have to reduce the sensitivity,
Mm.
or you have to change the polarity of the sensitivity. For
Okay.
example, you test your lead, you find the bipolar R wave is 2. So you must now test the unipolar R wave, see how big the unipolar R wave. And the unipolar R wave, for example, is 4 or 5. So you program your sensitivity now unipolar rather than bipolar, because your bipolar sensitivity and R wave is very small, and it will result in undersensing overpacing.
ده دكتور
Most of the
حسين
time,
معلش
this is
بغض النظر عن السنسيتيفيتي كم يعني فور اكزامبل لو انا لقيت السنسيتيفيتي مثلا 5 قبل ما اغيرها ليونيبولر ممكن انقص السنسيتيفيتي اشوف البايبولر اوفر
yes. You can change it. For example, لو لقيت السنسيتيفيتي بتاعتك is good bipolar, لكن البروجرام sensitivity in the pacemaker is high, so you can reduce your program sensitivity. Well, most of the time, this type of loss of sensing is due to micro dislodgement of the reed.
اوكي
Because you can see clearly it is capable of pacing. So this means that it is still attached or connected to the myocardium, but there is micro dislodgement. The tip is still on the myocardium, but the ring moved slightly away from the myocardium, and because of that, the sensitivity become low. طيب. On the other hand, oversensing, underpacing. Here, for example, let us start complex by complex. The first complex, you can see spike, you can see QRS, and in the bottom line, you see clearly it labeled with V-pace. So the device is pacing appropriately. Here, there is another spike followed with a QRS, and the device is capable to see that, so it is V-pacing. There is a QRS, the device sent that QRS, and as a result, did not pace. But after you see in the service ECG, there is a T wave, not followed by anything, no QRS after that. But if you see the line below, it's showing V-sense, means that there is ventricular sensing activity. So the device saying that I can see an R wave, or I can see the ventricle is depolarized. So as a result, it withhold pacing. It stopped pacing because, as you said, this is demand pacing for bradycardia. So no need for pacing because I have seen a QRS, but there is no QRS. So this is basically oversensing. And as a result, they will not be a pacing. So the danger of oversensing is bradyarrhythmia. The patient will not get pace. The danger of undersensing, the patient will get tachyarrhythmia. He may develop ventricular tachycardia or ventricular fibrillation due to pacing in the wrong time. Again, you can see on the service ECG there is nothing, and the device saying V-sense means that it senses ventricular activity while there is no ventricular activity. After that, there is a true QRS, and the device say V-sense, but even it shows us another sensing event after the T-wave. So this indicates that the lead is really oversensing. Most common cause of oversensing is interference. There is some interference from the environment, like electromagnetic field, or dithermy, or dithermy if the patient is under operation, for example. MRI scan. So all that can give you oversensing. So oversensing put the patient under the danger of dying from bradyarrhythmia, especially if he's pacing dependent. Clear? Any question about this? No.
Clear.
Okay. Type question. We have a device A with program sensitivity 0.5 millivolt, and we have device B with program sensitivity 2.5. Which one is more sensitive? A or B?
B.
A.
Who said B?
I said B. Low sensitivity, so it captures everything.
So it is 2.5 millivolt.
Yes.
So if the QRS is 2 volt, is going to be able to capture?
No.
No. If it is 2 millivolts, it will not be captured. Like the other device is programmed at 0.5 millivolt. If the R wave is 2 millivolt, will it be able to capture or no? Will it be able to see? Yes. So the
شوف
device
لي
which is more sensitive, A.
yes.
Yeah, A is the most sensitive. لأنه the sensitivity number is low. So it will be able to detect all type of activity 0.5 millivolt or above. While the B is only going to be able to detect the activity more than 2.5 millivolt. So anything below 2.5 millivolt will not be detected by that device. So it is less sensitive. Okay. So what is happening here? Is the pacemaker sensing appropriately?
This is a non-capture beat. Non-capture beat.
What is a non-capture beat?
We still don't have a QRS follow the spike followed by the QRS.
So that's capture.
This is capture. No, we don't have it here. We have a BVCs here.
Do you think that's a BVC?
Yes, I think this is a BVC.
Why not a pacing QRS, a based QRS?
Well, it's not sinus rhythm, right?
What is the underlying rhythm?
Sorry?
What is the underlying rhythm here in the ECG?
A sinus dysrhythmia?
Flutter.
Flutter. It is
Flutter, yes.
atrial flutter. So the underlying atrial rhythm is flutter.
Yeah, flutter, yeah.
So let us start from the beginning. Let us start from lead 2. From the left. What do you see here? You see a narrow QRS. Then after that, 1, 2, 3, 4, 5, 6, 7 big square, and there is no any activity. And then you see spike. And after that spike, you see a QRS. So this most likely is a base QRS, because it is fall after almost 8 square from the last sensed event, which the first QRS. Then you see another QRS. What happened before that QRS? There is a small spike. If you look at AVF, look at lead AVF, where I put my arrow. There is a small spike, but that spike is followed by another QRS. So this is what we called pseudo capture. The spike did not capture the myocardium. What happened? The device is delivering the depolarization, the pacing spike, while the myocardium already start to depolarize from intrinsic rhythm. So it will give you the spike just before the QRS, but the QRS morphology is completely different from the pace QRS, which we see before that. So this is what we call pseudo capture. There is a spike, there is another QRS, which is not basically base QRS. It just happened after the spike because both the spike from the device and the intrinsic QRS happen at the same time, simultaneously.
The concept, Dr. Hussein, looks like a fusion beat in VT.
Like it is capture beat in VT. The
Capture.
concept of that, the fusion beat. So there is normally in VT or in pacing, the same concept actually.
Mhm.
The true VT beat will be a wide QRS.
Mhm.
The intrinsic QRS will be narrow,
Mhm.
which basically the capture beat.
Mhm.
The fusion beat will be something in between. Neither wide like the VT beat, nor narrow like the intrinsic beat. It will be something in between.
Mhm.
So here, it is too narrow to regard it as a fusion beat. I will call this similar to the capture beat in VT. You get that? Yeah.
Okay. Okay.
Yeah. So this is basically a capture beat. And after that, you see a QRS, which completely different from the QRS of the base spike. Because if you, the second QRS for in lead 2 is the basically the base QRS. This QRS is not similar to that. And the spike actually happened after it. So this indicates that this is most likely BVC. So here, you see spike here, you see spike here, you see spike here. You see, if you look here, by the arrow is showing even a spike in V1 happening after the nerve QRS completely happened. So the sensing is not accurate from the device here. The device is under sensing. And as a result, it is overpacing. And this indicates the lead is most likely displaced. Clear يا شباب ولا too complex?
Please. But happy enough, the patient has good intrinsic rhythm.
Yes, yes. Fortunately, the patient is not pacing dependent.
Mm.
So this is basically a patient with what we call atrial flutter plus AV node disease, but the AV node disease is not too advanced yet. He still have some intrinsic rhythm. طبعا ultimately this patient will in the future become pacing dependent because the conduction system will continue to get damaged, and as a result they will become totally dependent in future. So you must rectify this issue now. So normally most of the time such type of failure of sensing, you try to see if you can program around it. Normally for any lead malfunction, don't rush to replace the lead. Always try to see if there is a programmable alternative for the patient. شباب والله الساعة 9:04 ولسه ما عملت أي حاجة في البرزنتيشن بتاعي، فما أعرف نخليه لحد يوم الجمعة الجاية.
خلاص it is okay. هي طبعا يا دكتور حسين البيس ميكر دي يعني احنا we are very happy انه يعني الشرح ممتاز جدا والناس بدوا يفهموا الحاجات، عشان كده لو مشينا بالراحة بالراحة بيكون أفضل. ولا
عشان
رأيكم شنو يا شباب؟
افضل. ايوه.
نوقف هنا. طيب في أي سؤال في الكلام اللي قلته سو فار؟
أسي زي البيشن ده دكتور حسين، يعني الفيرست ستيب انه اقلب البروجرامينج ليوني بولر.
أول حاجة طبعا هو دائما فيرست do chest X-ray. If you do the chest X-ray and you find the lead,
in
for
position.
example, just at the atrioventricular junction, here, even if the programming going to solve the problem, I wouldn't use the program because the lead is displaced too much. And even if I can play with the programming, long term, this lead will stop working at all. So first step, normally in any lead malfunction, your first step is to do chest X-ray. See where is the lead. Okay, and you need to do few maneuvers to make sure that the integrity of the lead is okay as well. So with presence of programmer and ECG machine, for example, you do check the impedance, the change in impedance if the patient move his arm, if there is a noise detected by the programmer when the patient is, for example, pushing against resistance by his left arm. After checking that the lead is good, it is functioning well from lead point of view. There is no sign of lead fracture or insulator break. And checking that by the X-rays, the lead is not displaced too much. Then you can always, the default is to try to program around it. Micro lead dislodgement is very common, especially in active fixed lead. لأنك مثلا during the procedure you screw the lead well, but the ring of the lead, most of the time it is the ring of the lead rather than becoming, most of the time you want the lead to be against the myocardium. It changed, it become at right angle to the myocardium, and as a result the ring is away from the myocardium. So that's why the sensitivity changed. And most of the time here, changing the polarity or lowering the sensitivity can help.
Also the micro fractures of the lead and these things بتتأثر بالأكسس، يعني هل السبكليفيوم بيفرق من الأكسيلري؟
أكيد السبكليفيان طبعا now most of the people will move away from the subclavian or moved away from the subclavian لأنه the reed fracture is very common with subclavian. طبعا السبكليفيان ذاته خشن بيوز زي ما بقول، يعني في very medial subclavian puncture and that almost always will get lead fracture because the lead will be directly below the clavicle. And the risk of fracture is very high. The a little bit lateral subclavian axis, the lead may be less likely to get fracture, لكن the risk is there still. Here, most of the type of the fracture is the operator went very medial, and sometimes the operator go between the joint actually of the sternal area and the first rib. And this normally rough operators, they will go against resistance because he just think that he can anatomically this is the location of the subclavian, and as a result he will get the subclavian eventually, but he will get it between the joints, sternoclavicular joint or what you call the osteochondral joint. So yeah, so he will get the lead fracture easily. عشان كده خاصة الموst susceptible to fracture the large diameter lead like a defibrillator lead, 9 French lead for example, is more likely to get fracture, especially it is very firm lead.
Okay.
Any other question ولا نقول سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك وقابلكم الجمعة
شكرا يا دكتور، جزاك الله خير.
الله يبارك فيكم. السلام عليكم.
Thank you very much, Dr. Hussein, for this nice
Thank you,
lecture. Thank you
Dr.
very
Hussein,
much.
for this presentation. It's really appreciated. And thank you, Dr. Dasugi, for this coordination.
لا إن شاء الله.
Thank you very much, Dr. عمر، وحياكم الله جميعا.
بارك الله فيكم.
مع السلامة. مع السلامة.